Bonjour, je m'appelle Dr. Ramesh Zacharias. Je suis le PDG et directeur médical du Centre d'excellence sur le douleur chronique pour les vétérans canadiens. Aux anciens combattants présents aujourd'hui, merci for votre service. The title of this webinar is The Impact of Service on Women Veterans, a look at chronic pain and transition. The CPCO is excited to host this webinar today, exploring how military service uniquely affects women veterans, focusing on chronic pain and the transition back to civilian life. This event will delve into the complex challenges faced by women veterans, highlighting current research on chronic pain's prevalence, potential contributing factors, and the physical and mental health impacts that often accompany these conditions. Attendees will gain a deeper understanding of the resources available to support women veterans through the transition process, featuring expert speakers, personal stories, and interactive discussions. I would like to thank our three speakers today, Sergeant Retired Anouk Beauvais, Captain Retired Hélène Lessaleur, and Dr. Joy McDermott, who is a clinical epidemiologist, physiotherapist, implementation scientist, and distinguished professor of physical therapy. I would also like to thank our moderator for this webinar, Lieutenant General Retired Jean-Marc Lanthier. Lieutenant General Jean-Marc Lanthier joined the Canadian Armed Forces in 1989 as an armored officer after graduating from the University of Ottawa. In senior roles, Lieutenant General Lanthier was Chief of Program at National Defence Headquarters and Commander of the Canadian Army, later becoming Vice Chief of Defence Staff until his retirement in 2020. Jean-Marc.
On behalf of the Chronic Pain Centre of Excellence for Canadian Veterans, welcome to our 2024 Fall Webinar. It is my pleasure to be your moderator for today's session. It'll be divided in two main parts after my initial remarks. We'll first hear from Sergeant Retired Anouk Beauvais and Captain Retired Hélène Lessaleur, and they will share their lived experience from their service in the Canadian Armed Forces and their subsequent transition to civilian life. We'll then have the pleasure of hearing from Dr. Joy McDermott, who will address the issue of sex and gender in the health of women veterans. There are two streams to choose from today. There'll be the French language and the English language streams. We'll be providing simultaneous translation, and all the support materials have been translated. The presentations and the slides are both best viewed in the full screen mode, and then we'll take questions after each individual presentation. But first, let me set the scene for today's session. Women have been in the Canadian military service for more than 100 years. Their numbers have fluctuated over the years, with the largest number serving during the Second World War. Women were allowed to serve again in the early 50s in traditional roles in medicine, communication, logistics, and administration. Their role only began to expand in 1971 after the department reviewed the recommendation of the Royal Commission on the Status of Women. New employment opportunities expanded into other roles, such as drivers, mechanics, military police, and firefighters. There was steady progress, but in 1987, occupations and units with the primary role of preparing for direct involvement in combat on the ground or at sea were still closed to women. The CAF conducted trials to study the impact of employing men and women in combat units, and that led to all occupation to be open to women in 1989, with the exception of submarine service, which only opened in 2001. As of last year, women represented 16.5% of the CAF, and that amounts to about 15,000 women. 16% of the CAF veteran population are also women, and that's about 75,000 women. The RCMP history of women in the police force is very similar. In 1970, the same Royal Commission recommended that enlistment in the RCMP be open to women, and in May 1974, the RCMP announced that it was recruiting women for the first time in its 101-year history. Today, women represent 21.8% of the police force, and that's about 4,200 women. Those numbers are not insignificant. They represent a very important contribution to the defense and security of Canada, spanning decades of service. Yet, the recently published report of the Standing Committee on Veterans Affairs, titled Invisible No More, The Experiences of Canadian Women Veterans, states that despite some recent progress, women veterans largely feel that VAC programs have not taken sufficient account of their particular needs and concerns. They feel that they've been left invisible. The AGVA report brings forward 42 recommendations. In its response, the government accepts fully or in principle 38 of those recommendations and takes note of another 3. If and when the government delivers on those recommendations, serving and retired women will benefit from increased scientific knowledge of their unique health and well-being issues amongst health practitioners and policymakers, access to better design equipment, improved rehabilitation services, better career and transition support, improved access to childcare and family support, increased support to prevent homelessness, and better access to community organization. What is absolutely critical to note is that all those issues identified in the AGVA report and that will be highlighted by Anouk, Hélène, and Joy today are not issues to be solved by women for women. They are deeply rooted institutional issues that must be addressed by a unified, coordinated, and synchronized institutional response. Equipment must be specifically designed and tailored for the women anatomy. Women are not small men, as you'll hear. They have unique anatomical structures and systems. Their health requirements differ and require specific and specialized knowledge. Their family and societal role, often linked to their gender, demand specific policies and support. Progress has been slow. The Government of Canada launched its Women's Health Strategy in 1999, but the Canadian Armed Forces just recently established a Directorate of Women and Diversity Health. The CAF prenatal and postpartum program has only been recently implemented. It endeavors to reduce susceptibility to musculoskeletal injury and accommodate women during the distinct life stages of pregnancy and maternal leave. There's a lot more to be done. This progress does not yet impact those who have retired. The AGVA report can be a catalyst and a call to action for all stakeholders. The CPCOE is well positioned to support the research that is needed and to lead knowledge mobilization effort. So let me now introduce our first speakers. Retired Sergeant Anouk Beauvais served in the Canadian Army Reserve from 2000 to 2010. She deployed to Bosnia and Herzegovina as a combat engineer and to Kandahar, Afghanistan, as a psychological operations analyst. During her military career, Anouk completed a bachelor's degree in public communications from Laval University and a master's degree in international studies from the University of Montreal. After retiring from the CAF, Anouk was employed as a humanitarian worker for various organizations in many countries affected by war and natural disaster. Anouk's humanitarian career came to an end in 2016, following a diagnosis of post-traumatic stress disorder linked to her mission in Afghanistan, and she also suffers from chronic pain due to a Jeep accident in Bosnia. Retired Captain Hélène Le Salaire enlisted in the Canadian Armed Forces at age 17, joining one of the first female cohorts in the infantry. Transitioning to regular force in 1999, she served 17 years primarily as a healthcare administrator, with notable deployments in Yugoslavia and Afghanistan. For her work in Afghanistan, she received a commendation from the commander of the expeditionary forces and later served as aide-de-camp to Governor General Michael Jean. Following a 2016 retirement due to PTSD, Hélène pursued doctoral studies to support military personnel transitioning to civilian life with operational stress injuries. Let's now listen to our speakers. Anouk and Hélène, the floor is yours.
Hello, everyone. It's a pleasure to be here with you today, joined by a great friend and a comrade in arms, Anouk, to share our journey with you.
Hi, Hélène.
Hi. When I joined Le Régiment Maisonneuve in March 1990, I was one of the first women to join the combat arms. There may not have been any women in the infantry, artillery, or armored corps, but there were other branches in the Canadian Armed Forces. So when I think about it today, I find it hard to understand why we were not given the proper equipment for training. For my part, I was issued with boots that were 2 sizes too big, and my combat uniform was also too big. My trousers were so long that I had difficulty to tuck them in so that I could, use my elastic band to held the edges of my trouser on top of the boot. It took over a year for me to get the proper clothing. But it's surprising because we all got our clothes from the base clothing store, like the folks from the regular forces. So it was not because there was less for members of the reserve. Was it still like you? Was it still like that for you, Anouk, when you joined the CAF?
Yeah, when I started my basic training with the CAF in 2000, so 10 years after you, Ellen, it was still exactly the same equipment. There still weren't many women on my basic training course. For instance, we were 5 or 6. On my combat engineer trade course, I was the only woman. So the equipment was still the same for everyone. Women and men received identical copies of every items for field training. Only the dress uniforms were different. Remember, there was a skirt and tall boots for women. That's it. So when joining the forces, we not only had to erase our feminine identity, but also wear the exact same combat gear as our male counterparts. This combat gear, designed for the average man, wasn't suited at all to the average woman's body. The rucksack was too long, would hit the lower back on the hips. You remember, Ellen, the rucksack from the 90s?
The famous rucksack. No solution was a winner. The steel frame was a standard size, so when I carried my rucksack, all the weight was on my shoulder because the bottom of the frame was lower than my bum. So nothing but my shoulder to carry the load. So after a lot of suffering, I decided to modify mine, which was not supposed to, was not authorized either. So I used a belt from my combat gear, which I had found, and it was a little bit wider. So to put on the bag, and then to put that on my hips to distribute the weight properly. But the problem is that it got too high. So with the helmet on my head, I always found myself with my head tilted forward like this.
Yeah, I kind of did the same with the rucksack, Ellen. So I understand it. It reminds me, in my case, with my hair bun, the combat helmet was always crooked. It gave me a really bad neck pain, and I was getting teased by my male colleagues that I looked like a wreck, right? It wasn't pleasant at all to feel unprofessional, but it was my bun that was, taking the space. It was not meant for it. Honestly, the rucksack, the helmets, the boots, combat vests were never designed with a woman's body in mind. Never. It's important to understand that soldiers, especially in combat arms, do a lot of physical exercise and activities. If we look at the standards for professional or Olympic athletes, for example, sports and high performance equipment is mostly always adapted to men and women. Bike seats, hockey protective gear, skis, even hiking backpacks are available in women's design. And this reminds me of the 13 kilometers individual combat fitness standard. Remember the 13K? Who doesn't? So you remember that the standard was interpreted as requiring 55 pounds of equipment in our backpack, when in reality, the standard dictates that it is our personal 24 equipment that must be carried in our bags, such as sleeping bag, pair of boots, complete change of gear, towel maybe, shower kit. So we agree that at our height, our backpack will weigh less than that of a man wearing size 11 boots.
You're totally right. I remember very, very well because several times when I was doing my 13K, they would put either stones or other people's equipment in my rucksack.
Yeah.
So that I reach the famous the famous weight of 55 pounds. But beyond the inadequate equipment or questionable standards, there are things that could have been done that would have prevented the chronicity of my condition. On October 7, 2007, during my deployment in Afghanistan, the LAF 3 I was traveling in ran over an improvised explosive device, IED. 6 of the 8 wheels were turned off and they all imploded but did not rupture, which saved our life. I will never forget the feeling of the blast going through my body and choking me at the same time. We all suffered, what I would describe as minor injuries. My comrade was sitting next to me and I suffered a fractured sacrum. So I had an X-ray to confirm it, and my superior, who was a doctor, gave me some restriction for the first 14 days, but that was it, My injury was never reassessed after the mission. So to see if there was, any greater damage or lesion that would have not been seen at first glance. Nothing was done. I often had neck pain, but I told myself, oh, maybe it's normal. But in fact, it was when I became pregnant that I developed, enormous lumbar problems. So despite my accident in Afghanistan, they insisted on blaming my pregnancy. After giving birth, I developed enormous problem with my pelvic floor, uterine prolapse, rectal prolapse, incontinence, for which I had 2 surgeries. But once again, all these problems were attributed to the fact that I had a child. But when it was never acknowledged that this entire situation could also be linked to everything I had experienced in my career.
Yeah, I understand. I had a similar experience to you, to yours, Ellen, but as a veteran. After my accident in Bosnia in a Jeep Iltis, I developed lower back and neck issues, very painful ones. And by the way, same as you, right after the accident, I had x-rays done at the American base, and the only diagnosis was nothing's broken. So today we know that if you roll over a ditch in a vehicle, even if nothing is broken, it's important to go see like a physio, an osteopath, massage therapist, because the body experienced a trauma. So same when I became pregnant a decade or more later, I experienced incredible pain in my back, my SI joint, my pelvic floor, and that during and for several months after my pregnancy. However, like VAC did not officially acknowledge the link between my new pain and my accident. I only found empathy from one case manager out of 4 or 5. I really felt like my identity and my body were not respected as a woman who had served in missions in a war. Realizing that the programs were designed for soldiers but didn't account for gender-specific challenges like ours, I kind of felt a lack of recognition for the conditions that were already acknowledged, especially the connections between different parts of the body, because it's constantly changing. It's an ecosystem, especially when you get pregnant and give birth.
Totally right. And even though I had been seeing a physiotherapist for several years because I had constant pain in my lower back, my neck, and also numbness in my hand, they told me we don't do an MRI or a scan unless we know what we're looking for. It was only after I was released from the CAF, when I met my civilian GP, that I was told about chronic pain for the first time. It was only when I was in the civilian health system that I was officially diagnosed. And according to my doctor, much of this chronicity could have been avoided if everything had been treated properly from the onset of symptoms, and especially on my return from Afghanistan. To this day, I'm still fighting with VAC to have my condition recognized, as they have difficulty attributing everything to my service. As for transitioning, like you, Anouk, I was first and foremost a soldier. So I'd never dealt with anything related to my gender because it didn't make sense to me. My identity was tied to my uniform and my service. Not only did I find it difficult to position myself as a person outside my uniform, but I find it even more difficult to position myself as a woman and to assert the particularities of what that means. Such, for example, as being a mother who leaves her child behind to be deployed on a mission. I experienced a lot of judgment, even from some women in the service. So for my part, I already had worked so hard in the CAF to earn my place, to have the quality of my work and the value of my experience recognized. But to arrive in a civilian world and lose that recognition, I found it very difficult. When I shared what I had experienced, for example, in Afghanistan, people tended to minimize or question my experience as if it was not true. I felt that I not only had to justify myself, but also to prove that what I was saying was true.
Yeah, I understand. I felt invisible until the team at the pain clinic in Saint-Anne-de-Bellevue's hospital told me, Anouk, we believe you. We believe you're in pain. So it was the first time like people recognized my military and veterans journey. And Hélène, like these are our experiences, just you and I, but we know many women who have faced the same challenges. It's important to know that VAC and CAF are making efforts to improve services and programs. Yeah. The report from the Standing Committee on Veteran Affairs, called AGVA, released in June 2024, confirms the existence of these needs. And there is and will continue to be an urgent need for research to better understand gender-related needs at a scientific level in order to develop effective programs. The AGVA report only outlines recommendations, right? Which is a start, but there's still so much work to be done. And in the long term, these research, they will address these real needs. However, in the short term, we know that many women veterans are not receiving tailored services and are not recognized for their gender-specific pain challenges, such as pelvic floor disorders.
Yes, we're talking about generations of veterans who, although the camps are not changing their ways, have been left without answers or very little support for their realities. And this is still the case today, like you just said. The identity of women veteran is still difficult to recognize in the civilian world. So there's still a lot of work to be done to promote these experiences that should no longer be invisible. Thank you, Anouk, for sharing yours.
Thank you also, Hélène. It takes a lot of courage to share personal journeys.
Yep.
Over to you, Jean-Marc.
Well, Anouk, Hélène, thank you so much for your very insightful and courageous presentation. You've highlighted a number of issues here. We'll now transition to questions. We have a first question, and we have 8 minutes to do this portion of the Q&A. So first question to both of you. What is the most important thing an allied healthcare practitioner needs to know and keep in mind when working with this demographic?
I'll go ahead with that, Jean-Marc. So I think it's all about being culturally competent. It's one thing to be competent, you know, in your healthcare system, but knowing about military culture, identity, and the mindset of people coming in the office of the healthcare professional is really crucial. And I guess that it's the most important thing, because you will not be able to treat the person adequately if you don't understand where they're coming from. So, for example, you cannot talk the way you will talk to an infantryman in the army, comparing to a person, for example, worked as a Navy and tech in the aviation, because the reality is not the same, the environment is not the same, the way they're doing their work is not the same. So it's really important for healthcare professionals to get that access to education about the military culture. So I guess, I don't know, Anouk, if you have something more to add to that, but it is my answer to this question.
Yes.
Thank you very much. Second question, I often find my chronic pain is minimized by healthcare providers. How does one get a voice and advocate? So I'll let you decide who starts.
Yeah, I'll start, Jean-Marc. It's not just about minimizing, it's about being understood as well. So it ties a lot with the education point I think Hélène was just mentioning, right? So beyond that, chronic pain often starts during, like, it doesn't start during the service. It starts often way later and you don't really understand it. Sometimes it takes years to be diagnosed after the release. So it takes really a lot of courage and perseverance to keep advocating, because yes, it's minimized. There's no understanding, especially with the integration of the body. So really, you need to keep advocating for yourself. You need to get up, have courage, and speak. So no one will come to your place, knock at your door and bring you somewhere to actually have health solutions. So it took me 20 years, and I'm still pushing for a lot of the invisibility I feel. So we must just not be discouraged and speak.
I think I would love to add one thing to that, is the fact that it's not because you were not understood the first time that you don't have to, you just leave the thing. You need to go again and go again, because at some point somebody will listen to you. So I guess it's, yes, like Anouk was saying, it takes courage and determination.
Yes.
Thank you very much, both of you, for that answer. We'll switch to a third question now. How do you approach the physical and mental issues of female veterans and serving members when it is not related to one single major incident, but rather a set pattern repeated over the years, and then they're both very different mechanisms. So what's how do you address that?
So I think the first thing to say is that, the pain we experience as an active member or veteran is not always from an accident like I had or an incident. It's like the compound effect, Jean-Marc. Like what I mean is like it's like a layer of cumulative impact, like the training, the equipment, the biological change, especially for women, and various other factors that can lead to chronic pain. So it's essential, I believe, to think about the biological, the psychological, the social, perhaps the also like even a spiritual aspect of a person to understand and treat chronic pain. Like we've learned that scientifically the nervous system plays a significant role in chronic pain. So it's crucial to integrate various type of care. I believe at least this is what works well for me, and I believe probably other veterans. So it needs that kind of like 360 degrees to actually deal with chronic pain, and a significant physical change such as pregnancies can affect women, exacerbate existing conditions. Human is an ecosystem, like I just mentioned, like before, like it's not just a list of isolated body parts. So I think it's understand to take that into consideration to feel understood. Ellen, I don't know if you have anything to add or.
All good. I agree with you.
Well, thank you, Anouk, for your very comprehensive answer. Another one just came up. What advice would you give to other women veterans who are just beginning their journey into or with chronic pain?
I guess it's like Anouk was saying, it's having the courage to just make a step forward and saying, my pain is real. My pain is something that I've been dealing with for a long time. And when you're recognized as, a person that is dealing with pain, and not only pain, but chronic pain, because like I was saying in my own journey, recognizing the fact that because it was not well addressed at the beginning, the chronicity installed itself, so it's afterward when somebody said, you have chronic pain. Oh, really? So believe in that when somebody is listening to you. And I guess it's the first step that you need to do for yourself. Advocate and educate also yourself. As a person, you need to understand what are you dealing with, because there's a lot of information that you can also bring, to your professional, saying, I read on this. Is it something that can be related to my condition? This is what I experienced in my service. And don't be afraid to talk about what you've experienced in your career.
And I'll just add, not to be discouraged. Yeah.
That persistence is
yes,
key.
Absolutely.
I'll cheat and I'll squeeze one more in our time. And that one is directed to you, Hélène. You said you're still fighting with VAC to recognize your injuries as due to your service in the military. What would it take to have your injuries recognized and compensated appropriately? How can we, healthcare providers, facilitate this?
Well, for example, everything related to the prolapse, everything that I was experienced with my pelvic floor, for them, it was not sufficiently it was not sufficiently documented in my medical history. It is in my file in the system, but for sure, nothing is related in my paper to something. But when you think about my entire career and what I experienced in Afghanistan, exploding, I was sitting on in the vehicle, and I just, so for me, having a professional sitting with me, and it's a long process, because it's dollars for them. It's dollars that it costs in time, which sometimes they don't have. So having someone taking the time to listen to the entire story of my career, and then being able to highlight where, situation might occur that would be contributing to what it is right now. And the fact that VAX, it was not related directly to a specific incident. They said to me, well, for now, it's just like we don't have enough information to recognize anything. But the thing is, I know that with the new report, they're working on that to have, women conditions recognized, and like Anouk was saying, the compound effect of a thing, to be able to bring that to the table and say, yes, it might not be one incident, but like an addition of a lot of things.
Thank you very much again
You're
for
welcome.
this very comprehensive answer. I'll do a wrap up at the end when we've heard all of our presenters. But thank you to both of you for your very candid presentation and answers, and thank you for listeners for your questions. That I think really sets the scene very well for Dr. McDermott, our next speaker. Dr. McDermott is a clinical epidemiologist, physiotherapist, implementation scientist, and distinguished professor of physical therapy at Western University. She is an adjunct scientist at the Institute for Clinical Evaluative Sciences. She holds a Canada Research Chair in Musculoskeletal Outcomes and Knowledge Translation, and the Dr. James Roth Chair in Musculoskeletal Measurement and Knowledge Translation. She's a fellow of the Canadian Academy of Health Sciences and Royal Society of Canada, and was awarded the Order of Ontario. Her research focuses on musculoskeletal pain and disability, physical and mental health and public safety, and veteran populations, outcome measurements, and the intersectional impact of sex and gender on health. She is a CIHR sex and gender champion. Dr. McDermott, thank you very much for joining us, and the floor is yours.
Hello, my name's Joy McDermott. Thank you for letting me speak about sex and gender in the health of women veterans. We're going to talk a little bit about some principles, some research, and their link to policy. To be on the same page, of course, gender is a social construct and sex is a biological construct. That means when we're talking about sex, we mean things like body parts, genetics, cells, hormones, physiology. When we're talking about gender, it's socially constructed. Psychological factors, social factors, and cultural factors. Of course, these sex and gender interact with each other, but we can think about that every cell has a sex and every person has a gender. Gender's not one thing. It relates to different aspects. There's gender roles. What kinds of roles do we take on in society? There's our identity, how we see ourselves and present ourselves. There's gender relations. How do we relate to other people in our workplaces based on our sex and gender? And there are differences in societal structures and supports that are institutionalizing power within society based on gender. When we think about veterans' health, it's a unique situation. Veterans enter as very healthy individuals. They're trained. They're provided good health care services, and yet when many veterans leave the service, they have a long list of health conditions that are listed on this slide. So sex and gender is an important consideration. It'll affect the risks of these problems, the way the disease progresses, treatment responses, and outcome. It's important to remember that women are not small men, and when women join non-traditional workforces, they cannot just assume the roles of small men in terms of equipment or how they're treated. Body structure in terms of bones and organs, body functions like hormones and physiology, and gender roles like roles in the family all affect men and women differently. I'm going to highlight an important report in this talk from the Standing Committee on Veterans Affairs, Invisible No More, the Experiences of Canadian Women Veterans. I won't have time to highlight all the recommendations, so I suggest you read it, but I will highlight a few and how they relate to what we know about women's health. Recommendation number 22 states that Veterans Affairs Canada and the Canadian Armed Forces, in partnership with the Canadian Institutes of Health Research, should fund a research program whose objectives include identifying the reasons for the higher proportion of service women who are medically released compared to men, the causes of musculoskeletal problems that affect service women more than men, the risk factors that explain why a similar proportion of medical releases exist for mental health problems in service women and men, despite the lower participation of women in combat, and the risks of military service on fertility and pregnancy. These highlight the diffuse areas of sex and gender that we need to consider. When we do consider sex and gender, we need to take a very holistic view, thinking about it with an intersectional sex and gender lens. What are the things related to the health conditions, their incidence, their prevalence, how they're diagnosed, how they're treated, and what the outcomes are that are being achieved? And could those factors, those differences, be explained by sex differences or gender differences in terms of biological differences or social differences? We layer upon this the exposures that men and women have in the military, and they will not have the same experiences. Things like military culture and identity and the support systems, what kinds of environmental toxic exposures, critical incidents and organizational factors are going to be different for men and women in the military, and these can all have health impacts. We need to understand these. Recommendation number 16 states that Veterans Affairs Canada should develop a list of medical conditions for which a presumptive link to military service would be granted when epidemiological studies indicate a higher prevalence of these conditions in veterans compared to civilians, and in women veterans compared to the general female population, and in women veterans compared to men. And the government response was they agree in principle with this recommendation. So let's look at that with respect to chronic pain in women veterans. Here is a systematic review and meta-analysis looking at many different types of chronic pain experienced by women in the general civilian population. And we can see for back, migraine, musculoskeletal pain, and others, women have a higher prevalence. So when these blue bars go up, these are individual studies, and that means that there's a higher prevalence in women. The red bar is the summary. So in all of these studies, we see women having a higher prevalence. This study looks at the prevalence of chronic pain in veterans, and we see that for veterans who, CAF members who were released, about 2/3 of them have chronic pain, and for those who remained in service, about half experienced chronic pain. So definitely higher than the general population. And then this study looks specifically comparing chronic pain in women veterans, illustrating that they have a higher rate of severe pain than men veterans, women civilians, or men civilians, therefore fulfilling the guidelines of that recommendation. However, this study makes another important point. It looks at sex differences in different healthcare conditions based on health services use and administrative data. And what we see from this slide is that in these particular cases, COPD, hypertension, and diabetes, men actually have a higher prevalence than women. What this illustrates is that intersectional sex and gender-based research and policy benefits everyone. It's important to understand the differences between men and women and gender diverse people, and to accommodate those differences and transform our services to provide equity for everyone. Recommendation 5 states that Veterans Affairs Canada should be more flexible in its assessment of secondary medical conditions, for example, chronic pain resulting from military sexual trauma, and the government agrees with this recommendation. This is data from one of our studies where we did a cross-sectional survey of 328 men and women who were either active military members or veterans who were all experiencing chronic pain. And we asked them about their experiences of different types of military sexual trauma, and found that the ratio of trauma was 26-1 for women compared to men when we talked about sexual harassment, and high for some others, but this was not consistent across different types of abuse. However, we did find that sexual harassment and sexual assault were directly associated with psychological distress, which was a significant pathway to severe pain, explaining 40% of the variance, verifying the importance of military sexual trauma as a potential reason for chronic pain. Recommendation 15 stated that the Canadian Armed Forces should hire more medical specialists and help civilian medical specialists to gain cultural competencies about the needs of women service members. And the government's response was that they take note of this recommendation. We can see why this would be much more complex to implement, given the fact that healthcare in the civilian population is governed at a provincial level. However, if we look at this research, this was a study looking in Ontario at healthcare utilization and data from over 7,500 military families compared to over 30,000 civilians. And they found that military family members took a longer time to get primary health care and were less likely to receive vaccinations. This just illustrates the challenges of going from a military service provision delivery of healthcare into the civilian healthcare system, which has its own challenges and difficulties, which are accentuated by the fact that military members may have to move. But when we think about this, that transition might be even more challenging for women, because healthcare providers don't typically think of women as being soldiers. Further, they are less likely to know about how the military service might have impacted on their healthcare and their healthcare needs. So this transition can be very problematic for women veterans. We decided to look at the research and see whether it tells us about sex and gender differences in treatment of military veterans. And what we used was, in 2016, it was recommended that all health research should look for sex and gender differences. And we wanted to see, was this happening? So we did this study where we looked at clinical trials, which should be good quality research, on two treatments: opioids, where we know there's sex differences, and rehabilitation, where we know there's gender differences. What we found were 20 randomized controlled trials that included men and women, one trial that only included men. None of the trials looked at whether there were any differences in treatment outcomes based on sex and gender. This is a fatal flaw in understanding how to optimize care. I'll end with this final slide, which looks at scoping all of the literature on Canadian Armed Forces and Royal Canadian Mounted Police, and found 84 articles, which might seem like a lot, but compared to the volume of research compared to men, it's really a drop in the bucket. So what this study really highlighted is there's little bits of information here and there about the health of women veterans, but much more research is needed to fully provide the right care at the right time for our women veterans. Thank you for your attention, and thank you to the veterans for their service.
Dr. McDermott, thank you so much. There is so much to unpack in that presentation. It could be a whole session in its entirety. So we've got questions, and we've got about 10 minutes for those questions. Let me start with the first one. What barriers do you see with women veterans in obtaining adequate pain control for chronic pain? How do veterans overcome the barriers to receiving adequate care and pain control?
So one of the first is the one that I mentioned about we really don't have good evidence. So for example, from the biological literature, we know that men and women have different receptors for opioids. The pain pathways in men and women are different. So I often say you should be able to go to your healthcare provider, whether you're a man or a woman, and say, how is my care or my outcomes from this treatment likely to be affected by my sex or gender? And they should have evidence upon which to answer that question. And clearly what the study indicated is they don't. So a lot of people are guessing or presuming based on maybe biological literature or low quality research about what those differences. So the first gap is we don't really have the information we needed. The second gap is the clinicians don't really understand how important that information is and seek it out. And they may not have gotten that information in their training. So they might not know how important it is to consider sex and gender issues when prescribing treatments. And then the third is as was spoken about, they also don't understand the military culture and how a woman with chronic pain from a civilian population and a woman in chronic pain from the military are going to present very differently. They're going to speak about their pain very differently, and they're going to have much more complex problems because there's often many exposures that women in the military have that even they don't know what they were. They might have been serving somewhere and there was a chemical exposure and nobody even knows what that chemical was. They may have had a physical trauma. They may have had military sexual trauma. They may have been on a vehicle where an IED exploded. So you put all those things together, how do you sort out which things are causing what? They're very complex problems, and clinicians are going to have a very hard time disentangulating what's causing what and treating things. It's not as simple, you go in with a broken wrist from a civilian population and you take pills for a week and it's better. It's much more complex than that.
Yeah, absolutely. I'll come back if I have time because I have questions myself, and I know the moderator's not supposed to have in the middle there, but we'll come back if we've got time. Let's switch to the second question. Is there any research towards the effect of menopause and hormone change, and how does it affect pain for women?
We know that hormones affect pain. And one time, quite some time ago, I read about an article on pain in people who transition. And this is an old article. It wasn't done very well. It was a small sample size. So take all of those caveats. But men who transitioned into being women had increases in their pain. And men who, and the other way around, women who transitioned into men experienced decreases in their pain. So the interesting thing about that study is these are people who had a certain amount of pain and they went under treatments that involved hormonal changes and that changed their pain. So that's a pretty strong, compelling argument about how hormones can affect your pain. But for women, it's not a simple thing because in life, throughout life, you have, first you get your period, and then some women have pregnancy, some women have multiple pregnancies, some women, and then there's menopause. And so the transition of hormones throughout the lifespan is changing, perimenopause. And we know that hormones affect pain, and that some of the higher amounts of pain in women are related to female hormones. How that plays out is really difficult. There have been an increasing number of questions to ask if women in military service experience menopause earlier. I hear many women veterans asking about that. I also hear the same thing from public safety personnel, women serving, asking, and there does seem to be some emerging data that maybe menopause is earlier. So how is that going to affect your health as well if you go through menopause earlier? So all of those things are going to affect women's pain for sure. Again, another complex issue, and we don't have enough research on that. But we do know that it is important to consider that women have a very up and down course with their hormones across their lifespan, and it's going to affect their pain experience.
Thank you for this very thorough answer. The deduction there's so much left to be researched to really understand. I certainly wasn't aware of how pain perception according to sex and gender was actually different. So very interesting to hear. You've mentioned something about other first responders, and there's one question that is asking: are these findings and themes related to female veterans relevant to female first responders? And where are the differences and similarities?
There are a lot of similarities. I mean, there are a few differences because, of course, public safety personnel can refuse some work and military personnel cannot. So that does create some differences in exposures. Having said that, public safety personnel are often reluctant to refuse any work even when it's dangerous to them. So they also have high rates of traumatic exposures and exposures to for example, women firefighters are exposed to toxic chemicals. They're exposed to high musculoskeletal demands with the equipment that they have to wear, and they are exposed to traumatic events. So I think it's really important that we work with our first responder community to recognize, because some of the cultural differences and some of the exposures are the same. But I think it's also too important to recognize that there are military culture that's also different. And even within our safety communities, so paramedics tend to have a different culture than firefighters and then police. So we have to recognize the importance of those different unique cultural groups and how their culture really impacts on all of them and their experience that they have in their service. But there are a lot of similarities in the types of exposures. Women firefighters complain about not having the right size equipment and it doesn't fit them as well, so they have the same problem there. I think working together with the public safety community can be really important, because sometimes you need to get the numbers to do the research, or you need the numbers of people demanding for better sex and gender services that consider that women don't all do the same kind of work, that women do some very rigorous jobs, and that the women who do that type of work have special needs. So yes, I think we can collaborate together while still recognizing the unique differences in the different sectors.
Thank you. Are you aware there is as much research being done for first responders as there is for the police, the RCMP, and the Canadian Armed Forces?
I personally work with firefighters more than some of the other sectors, so I'm more aware of the research in the firefighter sector. And in the fire service, about 4% of the service are women. If you're talking about career, if you're talking about volunteer, it's even higher proportion of women. So they certainly experience even the same working in a male-dominated environment to a very large extent, because when it's 97-3, it's a pretty male-dominated environment. They experience higher rates of chronic pain, higher rates of musculoskeletal disorders, and there are certain cancers that they need presumptive legislation around. And I think the firefighters have been successful in getting presumptive legislation for certain cancers that can be expected to be related to their service. It was a little easier in men because, of course, when you have more numbers, it's easier to prove you have presumption legislation. So think about the impact of that on women. So breast cancer, uterine cancer, those types of things may not be as easy to prove presumptively as men because of the numbers, but there certainly is work in that area. And there are a number of provinces that have presumptive legislation that recognizes certain cancers are more likely to occur, and it's presumed if you get those cancers, it is related to your service. So those presumptive legislation can be really important in accelerating people getting care that recognizes that their injury or illness was related to their service.
Thank you. Next question. What critical research do you believe would most advance support for women veterans care?
I think we need more studies, good clinical trials that look at sex and gender differences in different treatment pathways. All of that research should be co-designed with veterans from the outset, from day one. If you're developing a new intervention, it should not be asking a veteran at the end of after you've developed the intervention what they think. It should be developing the intervention with veterans to understand what their needs are, designing the treatment program based on their needs, and thinking about the different contexts which they get care. Because once they are transitioned out of military health care, they could be in a rural community without access to specialists. They could be very far from certain services. Like, how do they get the best quality care? That needs to be co-designed with veterans from the beginning. And then the study needs to look at, it's very likely that the treatment needs for men and women are going to differ. And there has to be flexibility in how interventions are delivered and what components they have and what outcomes you look at, because they could be different based on sex and gender. So thinking from the very first day you think about planning an intervention to the end of the study, it has to incorporate veterans' needs and preferences all the way through.
Absolutely critical. Thank you for highlighting this. And this is certainly one thing that the CPCOE has been working really hard to do, the inclusiveness of veterans' perspective. Switching to the next question. What is known about chronic pain in women veterans who are homeless or experiencing housing instability? Is there an influence on housing stability with health issues such as chronic pain?
There are people who know more about this than me. I'll start with that because this is not my research area, but I've read some of the research in this area. And we do know that chronic pain causes people to be at risk of homelessness because your income is impacted. It also there can be an association between chronic pain and addictions because people do things to self-manage their pain, especially if they don't have adequate pain control. Then you add on if there is an associated mental health problem like PTSD that's associated with chronic pain, which is often the case because the injury that caused the chronic pain can also cause the PTSD. So now let's put together PTSD, loss of income, loss of social relationships, addiction issues, and chronic pain. It's a recipe for homelessness. And then it's very hard to break that cycle when those things all, they don't just add together, they multiply. And you put them all together and it can be very challenging problems. So it certainly relates to homelessness. And then of course, once someone's homeless, that affects their ability to get appropriate care so it's like a downward spiral at that point. They can't access the care that they need. They're at risk of further trauma, and they're losing their social support. So it's a vicious circle that is but the beginning risk does start with an injury, chronic pain, plus or minus the occupational stress injury that might go with that chronic pain.
Yeah, the intersectionality in there is so critical. Both you and I think it's Hélène that highlighted it, the cultural awareness piece. It is so hard, even within the military, to understand the subculture. If you go large Army versus Air Force, but then if you dive in, your infantry or your logistic within the Army. I wonder if you have a view from a practitioner, an health practitioner perspective, or you've worked with them. How does one come to understand that culture? What resources are there except interfacing with the veteran themselves who will give them their perspective of their culture? But how do we raise cultural awareness in the health practitioners?
I think one of the most important things, and I'm a civilian, a healthcare provider, not a veteran. So I can imagine in my mind what a typical day in clinic looks like. A whole bunch of, and musculoskeletal conditions, a lot of older women coming in with, mobility aids and their gray hair, and they look like they're in pain and they tell you they're in pain. I mean, that's a normal day in clinic for a clinician. What's not normal to them is to see what looks like to them a healthy person, a young person walking in saying they're in chronic pain. And so when they see that person, they tend to think they're healthy and they underestimate their problems. Layer on top of that the military culture is mission first, that you do things even if they cause pain. You ignore pain. So now you have a clinician who's going to tend to not see the pain and a military veteran who's not going to tend to report the pain. And that's a problem because that's what makes it invisible, because it's not being seen enough in clinical practice. And the interventions that you would do for a 80-year-old person who's at risk of falling after a hip fracture are not the same treatment pathway for someone who is a military veteran who is relatively strong and mobile compared to most of the other patients in clinic, but they have very complex problems that need to be treated. And most clinicians are not aware of how that person's going to present. They're not enough aware of the complexity of their problems or what kinds of unique treatments might be needed in that circumstance.
Well, thank you so much, Dr. McDermott. Unfortunately, we're running out of time, and certainly so many issues have been raised by you and I know Hélène and by our listeners through their questions. And then each and every one of those questions probably deserves a fulsome explanation through some other educational resources. So thank you all for having shared your knowledge, your experience, and certainly your views on very complex issues. So complex because of that intersectionality, because sex and genders are different. Because even though these things have been around for literally decades, they're like a big onion to peel. There are so many layers in understanding that ecosystem. I think it's Anouk who used the word ecosystem, and understanding their complexities and interrelationship is absolutely complex, and we need to have more of those discussions. The Chronic Pain Center of Excellence for Canadian Veterans aims to bring hope to all veterans that are living with chronic and mental health conditions in their families. And I think you've all highlighted that rapport that exists between the mental health and the physical. They cannot be dissociated, and that's important to recognize they're both sides of a coin. To our listeners, I'd like to remind you that a recording of this session and all the sessions that have been performed before are available on our website. And any questions that you have as you review this or as you think through it, they can be asked through our site at the email that's at the site. Please don't hesitate to contact us for any other information you may require. And we'd also be very grateful if you give us some feedback on those sessions. Do you find them useful from a veteran's perspective, from a clinician perspective? If you have comments or topics you'd like to hear about, let us know. And that portion, we've raised so many issues here. The slides from Dr. McDermott are so packed of information. Have the time to peel in through them, and please recommend us other topics you'd like to hear about. So browse the website of CPCOE. It has a ton of resources and information. You'll find many educational resources linked to chronic pain management under the Veterans tab. And under the Resource tab, there's a lot of stuff. There's podcasts, there's webinar recording, there's key resources for clinicians. So thank you to Hélène, to Anouk, to Joy, and to our listeners. This concludes our Fall 2024 webinar series. We hope that you'll be with us next spring for more education. Subscribe to our mailing list so you'll be staying up to date. And on behalf of the Chronic Pain Center of Excellence for Canadian Veterans, thank you very much.